3, focus on the whole population, not just those who happen to come. You see, we've had this hospital and community thing all my professional life. But that implies, you see, the word community implies the hospital is not a community service. So what we've been looking at, and this is something I've been trying to do, I wrote my first article on this in 1983, called 4-box healthcare, not 2-box healthcare. And I showed this article to someone a couple of months ago, and he said, God, and I showed him the date. It's called Planning in a Time of Zero Growth. I said we should run the whole of healthcare so we know about asthma or arthritis or dying. Systems. He said to me, oh, it's very clever, you wrote that in 1980. Fantastic, he said, so clever. So I went and showed it to somebody else, and then I showed him the date. And he said, what the fuck have you been doing for 27 years? The answer is waiting for the bankers. You see, there are really probably only about 3 properly organized services. Cancer, end-stage renal failure, could be better, as we've heard, and now acute stroke. Everything else is Brownian motion, the random movement of patients, professionals, blood samples, and bits of paper. See, with fractured tibia, it's quite easy. Yeah, if I get run over out there, you don't need any clinical judgment or anything. Someone will scoop me up and take me in. But most of healthcare is not like that. And the people who receive the service are not the people who gain most from the service. And you see, some of the people who receive the service don't have the problem anyway. Well, that's inevitable. But we need to be aware of these things. So here's the new model we're promoting, in which we will do, we're going to promote in New Zealand too, is the concept of population medicine. So here's and this has been very well received actually by the specialists in England. In half my life I worked still for Her Majesty. And so here's a model. Dr. Jones, you see, is fantastic. She's everything you'd want, evidence-based healthcare, patient-centered healthcare. But Dr. Jones, how many people are there in East Sussex with COPD? And the answer is about 1,000. And she does an audit and immediately finds there's about 100 who would benefit from her service. So she wants to expand the hospital service. But Dr. Jones, there is no more money. So we want you to do a different thing, Dr. Jones. We want you to be the coordinator of a network of patients and clinicians, the East Sussex COPD service. We want you to do things like, I'll speak of the map of medicine. We want you to ensure patients get good information. We want you to find all the pharmacists in East Sussex and make sure they know about inhaler therapy or oxygen therapy. And we want you to produce an annual report. If you don't have an annual report, you don't have a service. We want competition for pride. I've done this in screening programs. It took me 5 years to get the median performance of screening programs in England to be as good as the 2 counties trial. It took me 10 years to get the worst program in England up to the 2 counties. Now, obviously, 2 counties who did the original trial had moved on that time, but efficacy to effectiveness. So this means we move to building systems. The 20th century was the century of the doctor. The 21st century is the century of the patient. The 20th century was the century of the clinician, of the hospital. The 21st century is the century of the system. And I'm now starting to run workshops where I'm banning the use of the word primary, secondary, acute, community, even hospital, except as a description of a bit of real estate. System, network, pathway. System, network, pathway. Language. Language creates reality. You have to use language and change the language. So here's a system. This took us about 5 years to develop. When we started, work with sickle cell disease, very tricky sickle cell disease, was Brownian motion, and took a young doctor about 5 years to do this. And here's other new language. Objectives, criteria, outcome, standard. Objectives, criteria, outcome, standard. And these are delivered by network. So here, In the old days, you see, this was professor, specialist, general practitioner. Nowadays, we have professor, pharmacist, generalist, patient. The patient is as important as the professor. There'll be professors in this room, I'm sure. Professors are very important people, I hasten to add. But they're doing a different job. If the patient doesn't take the medication, who's more important, the professor or the patient? So this is networks. A network is a set of individuals and organizations that deliver the system. And we use pathways, and the map of medicine. We don't use the map of medicine as decision support, but it's a means of writing things down. Wittgenstein said that every idea is a picture. You have to write things down. And it's very interesting when you do this, and you put this up, someone says, well, that's wrong. And I say, well, other doctors, who did that? Oh, other doctors did that. Oh, did they? And I don't really know how other doctors do their job, because we're all busy in our consulting rooms. So writing these things down, and the map's very nice. You can drag and drop these boxes. It's very elegant software. We don't use it as decision support. It's just a means of writing things down. The 19.5 whole-time equivalents as opposed to 2.5, we have to write things down. 5, manage knowledge as carefully as money. Now, most people get knowledge like that. Clean, clear knowledge is as important in the 21st century as clean, clear water was in the 19th century. And to get clean, clear knowledge, we have to organize it. The citizen cannot get clean, clear knowledge just as they cannot get clean, clear water. You can't go and dig a hole in your garden and get clean, clear water. Well, very few people could, I suppose. So a few people could get clean, clear knowledge off the internet. But what we have to do is to gather knowledge in reservoirs, and knowledge lies in reservoirs for a period of time, because see, we don't have to react to the new knowledge all the time. One of the reservoirs exist to cope with droughts. This is the reservoir for Glasgow. But if a sheep dies and rolls into the reservoir, the rubbish sinks to the bottom. And about a quarter of randomized trials are invalidated within a year of publication. So you don't want to act all the time on new knowledge. We need to manage knowledge and hold it and filter it. And then this is my equivalent of the internet. This is big pipes. The internet must be sort of big pipes, isn't it, up in the sky there? How did it happen? And this is a group of people even sadder than me. I mean, they protect ancient aqueducts in the Lake District. So there we are. But that's what the internet. But when it gets to the front door of the hospital, how does knowledge get to the 4th floor of the hospital or the consulting room? It needs pressure. Geraint, I haven't been able to spot your water tank, but somewhere up here there'll be water tanks. And this is the job we call the Chief Knowledge Officer. Who's responsible in your Department of Surgery for managing the knowledge? Not the librarian. It's going to be someone in the team who feels responsible for making sure patients can get new knowledge. It's a role, not a job. A role, not a job. And I was Chief Knowledge Officer for the NHS. And I took it on without any resources, except authority, to be responsible for getting knowledge.